Here is your stem.
Okay, ma'am.
Right. So if you've read and understood, considering it critical care scenario, please tell me what differential diagnosis would you consider and how would you manage this patient?
Okay, ma'am. This may be the case of gastric outlet obstruction due to the pylori stenosis due to the chronic duodenal ulcer. There may be the
Okay.
carcinoma of the stomach, gastric polyp, duodenal OF, carcinoma head of the pancreas, pseudocyst of the pancreas.
And next part of the question, how are you going to manage this patient now?
Okay, I will manage the patient according to the care of critical ill patient management protocol and ABC approach. I'll
ABCD
repeat
approach. Yes.
ABCD. Yes, I will check the air breathing and circulation. Here I will secure the IV line, give the isotonic fluid, 9% is normal saline and potassium supplement. I will introduce the catheter to measure the urine output, and I also correction the other electrolytes imbalance, and if patient is anemic, I also correct the anemia and monitoring the patient. Oh yes, ma'am, I also consider the wide-bone nasogastric suction to
Okay.
decompress the stomach.
All right. Why is that so?
Okay, ma'am. Here is the obstruction. For the decompression purpose, I will use the nasogastric tube. It also reduce the gastric content, reduce the edema, and maintain the gastric tonicity of the mucosal tonicity increase.
Along with this stem, there are certain labs in front of you. How are you
Yes,
going to interpret them?
yes, ma'am. The patient having the hyponatremia, hypokalemia, hypochloremic metabolic alkalosis.
Right. How are you going to take care of patients' metabolic alkalosis with hypokalemia
Yes.
and hypochloremic?
Yes, I'll for hypokalemia, I'll consider the potassium with the normal saline, and hypochloremia, I'll consider normal saline 9%.
Okay. Please tell me what is the pathophysiology which lies behind it or which is responsible
Yes, ma'am.
for this condition?
Okay, ma'am. And the hypochloremia due to the loss of chloride with vomiting, and hypokalemia due to the increased aldosterone in response to hypovolemia, and the hyponatremia because the kidney excrete more sodium bicarbonate uh, due to reduce blood
No, this
alkalinity.
is not explaining the pathophysiology, actually. Okay. Just tell me if you fail to manage this patient, what are the complications that you should watch out for?
Okay, ma'am. The patient was suffering from confusion, agitation, uh, fit cerebral edema, uh, seizure, tetany, and the herniation of the vein.
Not quite, no. Okay, please define the term succession splash. What is it?
Yes,
Succession.
succussion splash is when I uh, keep the two hand side, both side of the chest, and make a jerking movement, and keep my ear in front of the epigastric region. I'll hear the sound due to the fullness of the stomach.
On which side?
In the left side of the abdomen,
Yes,
left
left
upper
side.
abdomen.
Left side, okay. If I ask you to tell me, how would you classify the causes of gastric outlet obstruction?
Causes, ma'am.
Yes, please.
Yes, a chronic duodenal pyloric stenosis due to the chronic duodenal ulcer, carcinoma of the stomach, gastric polyp, mucosal diaphragm of the uh, gastric mucosal diaphragm, duodenal wave, periampulary carcinoma,
Okay.
pseudocyst of the
There
pancreas,
are
bijor.
other ways of classification of gastric outlet obstruction as well, other than this one. Okay, we'll come back to that later. Please tell me, how would you classify hyponatremia? Not just in
Yes,
this
ma'am.
patient, but in general. Yes.
Yes, ma'am. Depletional hypernatremia due to the diarrhea, diuretics, burn. Then dilutional hypernatremia, the heart failure, over administration of the 5% glucose in postoperative patient, and some endocrine cause like the addition disease, hypothyroidism.
Okay. And there is another type
Syndrome
as
of
well.
inappropriate ADS.
Okay, what are the complications of hyponatremia that can occur? Some you
Okay,
can
ma'am.
even see in this condition,
Yes, ma'am. Patient having
confusion
the
and fatigue.
confusion, fatigue,
Yes, and
confusion, fatigue, seizure, tetany, cerebral edema, brain herniation.
yes. Okay, why do you think this patient might have hypokalemia?
Hypokalemia due to the increased aldosterone in response to hypovolemia.
Right, correct. All right, please tell me. In this one, okay, I have not mentioned, but normally patient would, all right, when would you decide that this patient is fit to go for the surgery?
Yes, ma'am. When I observe the patient physical status is good, dehydration is corrected, electrolyte imbalance is corrected, anemia is corrected, and the gastric lavage was done and clear fluid is come out through the NG tube, and the other vital parameters and comorbidities is optimized, then I'll consider the patient for the surgery.
Okay. Why do you think this patient might present with aciduria?
Yes, ma'am. Uh, Here there will be the hyponatremia due to
Yes.
the stimulation of the aldosterone and angiotensin system, more
Wait.
sodium and what
Not due to, but this leads to.
this
Yes.
leads to
Stimulation
reabsorption of
of, yes,
stimulation of the angiotensin and aldosterone system.
renin,
The-
angiotensin, and
Then
yes,
yes, ma'am. Then
yes,
more sodium and water reabsorption in excess of hydrogen and potassium. So there
yes,
will be acidic urine due to the presence of hydrogen ion
yes. More hypokalemia and the urine will
and
be
more
more. Very
hypokalemia
good.
as well.
Okay. There is another condition which also results because of this. Because of hypovolemia, patient will also present with what?
Uh, Increase sodium bicarbonate.
Yes, and creatinine and urea
Yeah, yes,
will also be high.
creatinine. Yes, ma'am.
Yes, and bicarbonate will be high because, or will be increased. Why?
Because
Because,
yes, ma'am. Because there is increased uptake of the bicarbonate in the renal tubules uh, due to the loss of chloride in response to maintain the electrochemical neutrality, and another one is the reduce the pancreatic juice secretion due to the loss of acid load in the duodenum that results in the retention of the bicarbonate is pancreatic juice.
Oh, yes, not reduction, retaining.
Retaining, yes, retaining.
Yes. So, all right. And then management that you told me initially that you need to go back and read as well. That was also not correct.
Okay, ma'am.